On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Nourishing Health Literacy: How to Serve Up Better Understanding. My name is Kelly Gibson, and I will be your moderator for this program. We welcome any comments or questions. All materials are provided for your educational use. Now I'd like to introduce our speaker for the webinar. Christopher Mamrall is a Patient Safety Advisor with the Patient Safety Authority for the Southeast region of Pennsylvania. He offers an extensive and well-rounded patient safety background to his facilities. With his experience in the behavioral health field, specializing in quality improvement, data management, and facility-wide safety, he brings a distinct skill set and viewpoint to the Patient Safety Authority. None of the planners for this educational activity have relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Chris, I will now turn the program over to you.
Great. Thank you, Kelly, and welcome everybody, and thanks for joining me and the authority and all of us here on your Thursday afternoon. Hopefully you have something nice to eat, because if you couldn't tell from the pun-laden title, there's going to be quite a number of pictures of food throughout the presentation. So if you're hungry, I suggest you have a snack ready. It's not on purpose. I realize it was a lunchtime presentation, so hopefully everybody's okay and we don't cause some unnecessary cravings. Anyway, today, as we go through over the next hour, we're going to talk about health literacy. We'll talk about what health literacy is, how it's affecting us in the country and in PA in the healthcare system. Then I'll go over some barriers that we're facing when we try to address these and talk about how to overcome those barriers. Okay, and of course, we'll have some time for questions and answers at the end. So, what is health literacy? If I say health literacy, I think most people have a general idea of, okay, that's someone's ability to understand the information, but really we want to go beyond that. We want to empower patients to have the ability to make good informed decisions for themselves. Good is probably an objective word I shouldn't be using, or a subjective word I shouldn't be using, but we want them to make well-informed decisions. So if you're familiar with health literacy, if you've been on your health literacy journey for a little while, you might be familiar with some of the old definitions. And actually in Healthy People 2030, the Secretary of Health, the Advisory Committee on the National Health Promotion and Disease Prevention, looked at health literacy, and it's actually one of the overarching goals of Healthy People 2030, mostly related to health equity, those kinds of things. But within Healthy People 2030, they came up with a new definition of health literacy and divided it into two pieces. The first being personal health literacy, you see up on top, and this is focusing on individuals, their ability to find, understand, use information and services to inform health-related decisions and actions for themselves and others. Look at on that, it's decisions and actions. That's a nice little addition that they threw in there. Then we look at organizational health literacy. This is organizations. Are they equitably enabling individuals to find, understand, and use information and services to inform decisions and actions? So again, we're including actions, and we're throwing in that equity piece when we look at it from an organizational level, because we want to make sure that we're giving the same options, the same opportunities to all the patients that we treat, that we provide clinical services to. So those are the two definitions that are within Healthy People 2030. You'll see them kind of referenced throughout this presentation and in a lot of the materials I'll mention. But I also want to mention two other definitions and two other facets of health literacy. Really, digital health literacy is the first one, and this comes from WHO. It's the ability to seek, find, understand, appraise health information from electronic sources. So what are we finding on the internet? What are we finding on Dr. Google? Those kinds of things. Are we able to use these fancy patient portals that everybody has? Are we able to get and provide information through those means? This is an important aspect of health literacy, that as we see these technological advancements, as we put these processes into place to try and make the patient experience easier, smoother, we have to keep in mind what is the capacity of our patient load to handle this information, these new technologies. And the last piece there is this is included in health literacy, but I just like to mention it is numeracy, quantitative literacy. You can see why we call it numeracy. But this is really numbers, your math skills. So it's your literacy of math. This comes into play when we're talking about dosages and weights and things like that. There's a lot of numbers within healthcare. So it's important that not just be familiar with the terms, be able to read what were the instructions and understand what they're being told, but to be able to do those basic calculations and things like that are also important to providing safe care once they leave our facilities. So mentioned, we want them not just to understand that information, but take that information and use it to make well-informed decisions. So not appropriate, not the decision we think they should make. We're not always going to agree with every patient decision. Very often we're going to disagree with the decisions that patients make, but that's their autonomy. We have to allow them to make those decisions, but we also need to do our best to provide all of the relevant information for them to make those decisions from a place of knowledge and understanding. We want to look at this from a public health perspective. Obviously, we're addressing this as to the community as a whole. You want to kind of tailor a lot of your health literacy activities to the population you're serving. I'll get into it a little bit later when we talk about cultural influences and different language options and those kinds of things. But really, we know that this is not just on our providers. Yes, I'm going to go over tips for the individual. There's tips you can provide your patients. I'll go over some of the patient resources out there. But really, from an organizational level, we have an obligation to make sure that this issue is being addressed, not just because it's a goal in health safe in healthy people, or because it's a regulation or standard, whatever requirements are that are out there. This is really a way that we're going to communicate with our patients better, help build that trust, and end up with better outcomes for everybody. And really, the data supports that, as you'll see. So when we talk about health literacy, what kind of a problem are we dealing with? Only 12%. So we're looking at only 12% of US adults have health literacy skills needed. So that means 9 out of every 10 patients struggle in some way with health literacy. We're going to let that sink in. 9 out of 10 are having some struggle related to health literacy. This is because healthcare is complex. It's you introduce insurance and the different referrals if you need those, and different managing different overlying chronic illnesses. Those kinds of things can be very difficult to navigate if you have all of that requisite knowledge. If you're coming in without that knowledge, without that information base, it's even more complex, even more complicated to try and manage. And then think about it. We're dealing with people not when they're at their best most of the time. They're coming in. They're suffering from some disease state. They have an illness. They're coming in to address some complaint that they have. Maybe they don't know what's going on. Stress levels rising. We know the cortisol. We know the effect that has on the body. They're not going to be able to concentrate as well. There's the things that they might have understood when they're calm and in a normal conversation. They might not be able to grasp or fully comprehend or concentrate on while they're going through this health crisis. So keep that in mind. There's also a financial obligation. If we're looking, this is based on just an estimate for a mid-sized community hospital, about almost $2 million per 5,000 patients per year. So think about how many patients you have coming through your hospital, your surgery center, whatever, and look, this is costing us money because of people returning because they don't understand instructions, people not following pre-op instructions, leading to cancellations, those kinds of things. These chronic conditions, as we become better from a ability and the tools and the strategies we have for addressing these chronic health issues, people are living longer and they're getting more chronic health issues. It becomes more and more complicated. So if they're not able to manage even one of those health conditions effectively, it could lead to rehospitalizations, more doctor's visits, and you can see where the cost really balloons. So who is this affecting mostly? Really, it's everybody. When we look at health literacy, it's a better indicator of overall health than pretty much any other social determinant we can look at. But that being said, other social determinants do have an effect on low health literacy. Whether that's causative or not, we don't know. But so we're looking at our older adults. Obviously, we'll go over some of the specific reasons. There's hearing impairments, visual impairments, cognitive impairments that are associated with patients of those ages. Minority groups are still displaying either more below basic or basic health literacy skills compared to the majority Caucasian population, immigrant populations. Again, we don't have the simplest healthcare system in the world. So when it's a new experience to people, it can be very difficult to navigate, very difficult to understand how things have to be, the processes you need to follow to manage some of these issues. And then when we look at Medicare and Medicaid recipients, there's much higher rates of poor health literacy in the population than we see with those with employer-sponsored education. And again, there's overlap there, and you can see kind of some of the reasons why those groups are at higher risk. So they're higher risk. We have these health literacy problems. 9 out of every 10. What's happening? We're having medication errors. That's the big one. And I think you'll probably hear me use a couple of examples as we go through talking about health literacy. But med errors, that calculating doses. When do I take this pill? What pill do I take? Do I need to eat with it? Does this need to be refrigerated? There's a lot of instructions that come around our pharmacology, and that very often gets lost in translation, for lack of a better phrase. They have difficulty following their care plans. This is true, especially once we get too complex. If there's multi-step processes they have to go through, that can be difficult. They don't realize the benefit of preventative services or when those preventative services should be sought out. There's not that information of how to maintain good health when you do have it and how to kind of head off these issues preemptively. I talked about the increased readmissions. We use the ED more often than primary care physicians and things like that, or specialists. We're using that as an access to more basic care where we probably shouldn't be all the time. And of course, longer hospital stays again because of lack of information and compliance and adherence and those kinds of things for whatever reason. So, how do we know when somebody has poor health literacy? There's a couple ways to informal, and then the next slide I'll go over some formal assessments. If you don't already have one, there's a couple out there that I'll point you towards that are good. But from an informal point, there's things that you're not going to get from a form. Do you have patients that frequently miss appointments? Now, this might not be related to health literacy. It could, is somebody an introvert? Does somebody have a busy schedule? Is there other health issues going on that cause them to miss appointments? So this is, again, this is not a be-all, end-all. It's not saying that if this happens, they have a health literacy issue. It's just something to kind of, as a red flag to be aware of. Are they not completing forms? Are they completing forms but putting in misinformation? And again, sometimes people misunderstand things. But if you're giving them a stack of forms to fill out and they're only doing half of it or just the basic information and turning them back in, that should be a red flag there. When you talk about pills, are they looking at pills instead of reading the label? Are they calling them, oh, in the morning I take 2 blue ones or 2 blue and white ones and a red one, instead of calling medications by their name? Now that might be easier. That's it's a lot easier to remember red than a complex medication name. But again, that could lead to problems. I think it's pretty obvious where that could break down. Do they avoid following up on tests? If they have some type of diagnostic done, are they following up on those results? Do they know what those results mean? Do they know they have to follow up to the results, or they're waiting for something? Who knows? If there's doing cultures, do we understand that needs to take time? There's information that we might assume is common knowledge that is most certainly not when we look at the general population and their health literacy levels. We give somebody written materials that they say, "Oh, I forgot my glasses," or "I'm tired. I'll read this at home." That's kind of a red flag that there might be some issues there, and you can offer to kind of maybe go over the main points and cover things. Again, maintaining dignity, but helping with that, with those reading those materials. I mentioned the formal assessments. There's a handful mentioned here. These are all available in the ARC Universal Precautions tool I'm going to mention later. And you can get them through the Center for Healthcare Strategies as well. I'm not really endorsing one over the other, but you can see there's some out there, different care settings, different questions. Really, when you're going about this process from an organizational level and you want to look at implementing some type of formal assessment, look at your patient population. Look at where are you're meeting your patients. Are you a big university hospital system that you need to do some more advanced health literacy screening and can get in depth, and you're looking at different minority groups to address within your community and things like that. Or are you a surgery center and you just want something basic, like how are you going to be able to understand instructions that we're giving and things like that. So as you go through these, some are longer, some are shorter. I encourage you just to kind of explore a little bit before you pick one. And I'm pretty confident that most organizations can find one that pretty well fits their need. In Pennsylvania, this is, of course, an issue where we're right in the middle of the pack as far as the latest round of national assessments. Of course, that was done in 2017. We're due for one. There's been kind of a breakdown in different committees, and you guys know how government works. That can be kind of tricky. But in Pennsylvania, we still do have our Pennsylvania Health Literacy Coalition. It was originally created back in 2014. That's kind of being managed by the Healthcare Improvement Foundation, HCIF. You can see they do tons of educations that are out there, lots of ancillary resources. So if you're looking for assistance or you're looking to get involved with your community, with your public health system around your facilities, and you wanted to know where to reach out, I recommend they have a great website. You can go get information from them there and expand your health literacy journey. I mentioned the healthy people, the overarching goal that covers health literacy. Really, I mentioned it goes into that equity. So we want to eliminate health disparities, achieve health equity, and attain health literacy to improve the health and well-being of all. Okay, and you can see the objectives down there. I'm not going to read through them, but you can see we want to address minority groups. We want to get those patients that have low health literacy or limited English proficiency more involved in their care so they could be making those informed decisions. And better, we can communicate back and forth some of the factors that are playing into those decisions. What are some of the risks and benefits? It's important that all of that information is available so that they can make that good informed decision. So how do we have those conversations? When we scheduled this, I looked at it and I'm going to put my cards on the table. Thanksgiving is one of my favorite holidays. I understand the historical context is a bit muddied now and those kinds of things, and I'm not going to get into all that. But any holiday that centers around eating food and a lot of food and football is right in my wheelhouse. So when we looked at this presentation, I said, man, like talking to people and making sure that there's understanding, like it reminded me of Thanksgiving dinner. So as everyone's getting prepared, hopefully you're getting together with family, friends, whoever. We're going to see people we haven't seen in a little while. We're going to see people that maybe aren't part of our normal group. They're coming from across the country. They're coming from different part of the state. Whatever, they have different experiences, different language, different age groups, all sorts of different demographics coming into play at our Thanksgiving dinner table. So, how are we going to communicate with each other? What's the biggest problem we're going to face? The number one barrier, I bring this up because I think this is the number one barrier. Most of the time, and not even most of the time, almost all of the time, healthcare professionals believe we are communicating accurate information and that information is getting across. We feel there is a perception that we are accurately and effectively relaying health information. We're trying to, of course, the intention is there. That's good news. Less surprising than the fact that I think that over 98th percentile believe that we are communicating accurately when we look at surveys. On the flip side of that, a lot of times the patients feel that they understand what they've been told, and they might not, right? They might have a couple questions. Oh, I'm not going to ask that. That just seems silly because he explained it so matter of fact, like I should understand how it was. So there's a breakdown there of, okay, we believe that we're communicating. We're not recognizing that there's a problem. If we don't recognize that there's a problem, we're not going to put the work into trying to address this issue. I'm going to tell you right now, we have no control over whether those patients ask questions. We have no control over what the patients are responding when we give them this information and ask these questions. I don't need to tell all of you. I'm sure everyone on this call has an experience with something that a patient told them that didn't make sense. Oh, do you have any chronic health conditions? No. Are you on any medications? Yeah, metformin. What? It's for my diabetes. Well, that's a chronic health condition. There's a lack of understanding at every step of this process. And we have to recognize that. We have to understand that we may be trying, we may be doing our best to relay that information. Thinking we are is not enough. We need to have some type of feedback mechanism. I'm going to talk about it, and I'm sure you're all familiar with Teachback and the Acme 3 and all, a bunch of the other tools available, and I'll go over them. But really, getting this into our heads that we, even if we think we're looking at, I attended this webinar on health literacy. It was great. The speaker was fantastic. I hear he's very handsome too. And, I took these techniques back to my facility and I used them. And now I'm communicating great with all of my patients. Oh, probably not. You didn't pay attention to the last half of the presentation where we talk about how are we, assessing that we're doing this well. Are we communicating clearly? So again, I think the number one issue is the perception there that there's understanding, and is that accurate? Language. The language we use is super important. I'm heading out to my in-laws. We're flying about halfway across the country for my in-laws, and they have teenage children. I've younger children myself, but I'm very much looking forward to the teenagers. Because I remember what my cousins and us were like when teenagers, and we, there's it's a whole different communication style. Back in when I was a teenager, it was every other word was like, oh, it's like so cool. Like I was like, he was like, this was like, and now it's all sorts. Oh, bro, if I have one more teenager call me bro at a dinner table, and I'm looking forward to it for Thanksgiving, but there's these terms, we call it jargon in the medical profession, but slang. So when you sit down, you're talking to your teenage relatives. Are they using words you don't know what it means? Are they saying, "Oh, check out my drip. I got tons of Riz." I'm using these words. I don't even know. I have a 10-year-old. She baffles me sometimes. But this is what it's like for patients when they come in. We're surrounded by like-minded individuals almost all of the day. We're talking to our coworkers. We're talking to other disciplines. We have some shared background of medical knowledge, of medical understanding. So we get used to talking like that. Of course, we're going to take those shortcuts, and we're going to talk in language that we understand that's meaningful to us. That's not always the case when we talk to people outside of that group. When we talk to people outside of our peer group, when those teenagers go to adults, should we be calling them brah? Should we be talking, all these words? No, probably not. So you have to watch those things. Watch the terms you're using. Watch the turns of phrase, any colloquialisms. You don't know where people come. If we grew up in an area where we have a saying that everybody's familiar with, maybe the person's not from that area. So you got to keep that in mind as well. The speed of speech is big. This is one that I always see, and yeah, but Chris, we have so much information we have to get across. I understand that. There's a ton that we have to communicate to our patients. And I feel hypocritical saying this because as you've listened to me for the last 20 some minutes, I can speak rapidly at times, and I have to make a concerted effort to slow down. I'm sure Michelle, our director, is laughing right now because she's told me in the past I have to make a concerted effort to slow down. So keep that in your mind. Go back to, do I think I'm speaking slowly enough? I think I'm speaking slowly enough now. If I'm not, please pop it into the comments. I'm more than happy to slow down because if I start talking really fast, it sort of becomes harder to follow some of the concepts. And even though you want to understand, and you might understand the words and the phrases that I'm saying, and you can get all the words that are subbed into each sentence, and I'm keeping it in paragraphs, and I might take a pause to let you understand something. If I'm speaking real rapidly, it still can be very difficult to keep track of every single point that I'm discussing, and you can see how that can become burdensome as we go over more and more information. That was on purpose. You don't need to put it in the chat that I was speaking fast there. The other one that comes up, preferred language. This is pretty simple. I think this is something that the Joint Commission and other regulators we've kind of beat this into when we talk about the culturally appropriate language and things like that. I'm not going to go too much into that. I think that's more of a health equity issue, a very important topic, definitely worth addressing when you're filling out your evals. If you want to hear more on health equity and culturally appropriate care and things like that, please include that information. I think it's a very important topic. I'm going to hop off of that soapbox, but keep that in mind. Around our dinner table, we have people from all walks of life, all backgrounds, all cultural experiences, regional experiences. So we have to keep in mind that's going to change how they approach different topics. If I come from an upbringing that put a lot of emphasis on authority, it was a very paternalistic household, I'm probably going to do whatever the doctor tells me without questioning it. If I came up in a more I'll use the term laissez-faire environment, I might be more questioning. I'm more distrustful of what authority figures tell me. This all plays into it. Written materials, I'll talk about. Most health materials, no matter what regulations say, whether it's sixth grade level or we're aiming for third to fourth grade, whatever, most are written at or above the 10th grade level. Average is about 13th grade, which, that was confusing to me, freshman in college. So we're talking about a lot of our materials, especially our informed consents and the forms that require some degree of legalese, more than more than a 10th grade level. So, who are our patients? Well, if they've graduated high school, they read at a more than a 10th grade level. They should read at a 12th grade level. Yeah, but reading is much like anything else aside from riding a bike. You use it or lose it. So if you're not in school, you're actually reading about 3 to 5 grade levels below the highest grade level completed. So if you've been out of school for 10 years and you graduated college, you're reading at probably a freshman or senior in high school level. Keep in mind, this can be difficult, because it's oh, I graduated college, I understand like big words, I don't have any questions. The SATs was fine. Analogies, this is to so and so, whatever. We have that super educated uncle that shows up at the table and starts talking in big words and these concepts and oh, I'm a smart guy. I want to seem smart. I'm not going to say that I don't understand what you're talking about. I'm going to say, oh, that's so interesting. Like, can you tell me more about that? And am I going to get more information when he tells me more? Am I just going to get further into a hole of not understanding what is going on? So keep in mind, we want to speak not to where we think people are, but what below where we think they are. We want to go to I don't want to say lowest common denominator, but yeah, you want to make it as simple as we can. Simplify it to the highest degree, the lowest grade level you can. The simpler we can make the information, the more people will understand it, no matter how educated, no matter how informed, no matter how health literate they are. That information is going to get across. Nobody's going to be upset if you explain something too simply to them. If they understand the details, they might ask questions to get more complex information, but no one's going to get pushback for getting it too simply. I'll say that. Okay. I'm going to pull up this next exercise. This is a holdover from our previous health literacy materials. I'll admit that, but I just love it so much because I think it really shows what it's like when we talk about people with low literacy and when we give them instructions. So I'm going to show you a slide. I'll leave it up for about a minute. You don't need to read it out loud. It might be helpful. It might help with the translation, but you'll see every word on here is written backwards, and the first word is cleaning. So I'm going to give you a minute starting now. Hope everybody's please attempting to read it. Do your best. I know it could be difficult. About halfway. We'll give you guys about 30 more seconds. We'll see how many can get through it. Is there anybody that's finished? You just type in the chat if you're finished. Either nobody's finished or nobody wants to type in the chat. How about now? Is anybody finished? Okay. Oh, good job, Shirley. Okay, here we go. All right, now we're done. So that's our minutes up. So we had a couple. Oh, Bob. Hi, Bob. So we got some of you finished. Not everybody. That's okay, right? This is hard. So now, before I go on, those of you that finished, what is this passage about? What is this telling us to do, or how to do? No idea. Right? Because when the words are like this, we're focusing so much cleaning up grease and oil. Okay, yeah, it's cleaning. So I'm going to go to the next page here. We're going to look on it. So now we can read it. Like the words are pretty clear. I think we can read through this. We can sit to assure high performance, periodically clean the tape heads. This is instructions on how to clean a cassette tape player. How many people have a cassette tape player still? So when you're struggling with the words, just trying to get through, you're not going to get that overall message, right? So keep that in mind. We might make the message simpler. Like most of these words, we might not be familiar with isopropyl alcohol. What's a capstan? Does anybody know what a capstan is? Back to that jargon. I can't even. Yeah, so there's a reason we picked this. I struggle with that. Yeah, you can't read the word if we don't know what that word means, right? So not only are and this is not even factoring in dyslexia and other learning disabilities and things like that we need to take into effect. This is just standard literacy and a reflection of that. There's going to be words that your patients don't know. So we need to try and a capstan, sorry, is it's the reel that turns the magnetic strip, if I remember correctly. I think it comes from a nautical term of like it's a spool that lifts weights. It's some type of spool. You can tell I'm not exactly an expert as well. But if I'm saying like, oh, you got to clean your tape heads and the spool that does it in there, is that great? That's kind of tricky. Think about better ways. What's a better way for me to teach you how to clean a tape deck player? Probably to show you. Even better, have you show me once I explain it to you. And that's when we get into the teach back and the show me method and those kinds of things. What? What? I am skipping all over the place here. I think I clicked out. So yeah, it was difficult. We feel inadequate. We're struggling. I'm trying to read it and you're insecure, like, oh man, like I'm just struggling to get through the words. And we get to the end and like, I have no idea what that was about. Not in the slightest. That's a huge problem, right? So what do we do to address that? Before we move on, I want to share one thing, and this is I'll admit I went into a rabbit hole in this. So this is our low literacy passage. This is that passage written normally, obviously easier to read. When I mentioned I went into a bit of a rabbit hole, this is that passage in bionic reading. And I'm not going to go into this too much today, but I wanted to mention it because I think it's interesting. Is that bionic reading is a way to alternate bolding and lightening of text, and supposedly it draws you in and it makes you concentrate more and further comprehend that information and it I don't know, it's supposed to activate the brain on a higher level and get that information across. But if you're sitting here reading through this, you can kind of tell that you're pulled more into focusing. If you're not understanding what I'm saying, not listening to what I'm saying because you're so focused on this bionic reading. Just something I wanted to throw out there. I've seen a handful of facilities, actually a system that started using this, and they've reported some positive effects with it. So I wanted to present this as an option. So all of this, we have those terms. We're not familiar with the terms. If we're giving statistics, statistics can be super confusing to people. Not everybody understands statistics. Most people hated that class in school. I personally loved it. I know I'm weird, but statistics are confusing. People don't understand how, oh, we have 99% of retired football players that have CTE, but statistically, that's everyone. Statistics are weird. Not everyone understands them. Just keep that in mind if you're trying to relay risk benefit information using statistics. You want to simplify that. Don't say 25%. Say 1 out of 4. Those kinds of things. I mentioned several times that when we're scared, we're confused, we're stressed. Dealing with illness is not fun. We are never at our best when we are sick. We have to appreciate that. Good, Valerie. I see your feedback on the bionic reading. I get that. And when I've seen it, mostly it's not like a full document. It's really for like a paragraph to kind of draw attention. But again, if that's not meeting your needs, don't use it. Okay. So how are we addressing this? How are we making sure that all of our patients are getting the information that they need? I'm not sure why I skipped forward so many different slides here. I'm running into some issues. Okay, here we go. Very, very ironic here. As we go through this, I mentioned the technology. People might need assistance using their devices. They might not have much familiarity with their phone. They might not have a smartphone. So keep that in mind. You have these apps that are great for everybody. Most people do, but keep in mind, you need ways to communicate that information if they're not able to excuse me, to use the app, or if they're not responsive on the app, those kinds of things. The second bullet point here, this is a much larger topic than we can get into today. So again, I'll say if you're looking for more information on this, please include that in your evaluations. But trying to distinguish good information online from misleading information or misinformation or advertisements, those kinds of things. I think that's a topic in and of itself. I do want to touch on it, that when you're providing information, here's some tips from the national libraries. Like I said, this is a huge issue, a huge struggle for our entire healthcare system. So I don't want to go too much into it today, but just keep in mind that when you are providing information, you want to make sure that you're pointing your patients to good resources, to trusted resources. We want that trusted information to be what they're going to as their main source. Other issues, hearing impairment. I'm sure we all have that relative where do we need to speak louder? Louder doesn't always help. Sometimes we just need to speak slower and that'll help. Is there different materials we can use? Those kinds of things. What services do we have for our hearing impaired population? Likewise with visual impairment, if you have a lot of written materials that you provide, maybe have some alternates. If there's videos, if there's things that have an audio component can be very helpful when dealing with different visual impairments. Make sure you're not printing things too small. You have good sized fonts, those kinds of things. So those are some of the problems. We know they're problems. How do we make sure everybody's getting the food they need? How do we make sure that we're providing good care to everybody? I mentioned universal precautions. This is really, it's great. If we treat everybody if we approach everybody the same, knowing that they may have difficulty understanding the information, and we approach it with that understanding, we're in a good position to provide the best communication we can. I mentioned ARC's tool. You can see it here. It's the Universal Precautions Toolkit. The nice thing about this is it runs through from, you're just starting to set up a health literacy program. Here's how to do assessments and how to look at your organization, through written communication, verbal communication, using electronic sources. How are we monitoring it? It's a very comprehensive toolkit. It's not brief, I'll say that, but there's lots of good tools that you can use right in there from ARC. It's over 20 tools. Some of them you can see mentioned there. There's some great stuff on the teach-back method, which I'll go through, as well as suggestions for patient follow-up, tips for motivational interviewing, as well as information about language access and your phone lines and your different interpreters, things like that. So, verbal communication. First of all, you want to greet your patients warmly, make eye contact, sit down, take time with them. We want to earn their trust. We want to speak slower. We want to eliminate those complex terms. We want to make the terminology as simple as possible, even if it is a complex topic. And you want to make sure that they're understanding all that information that we're giving. I am just skipping. I don't know why I'm hitting the wrong button or something. So I'm gonna change how I'm doing that. So teach back method. I mentioned the show me method before. This is sometimes we might explain to somebody, you need to take 2 pills or 2 doses of two tablets of this medication in the morning. They may be able to say, yeah, I'll take 2 tablets of medication in this morning. Like, okay, show me how you're gonna take it. They might take only 1 pill out, because it's got 2 colors on it. I thought that represented 2, something along those lines. So not just can the patient explain it back to me and teach it back to me verbally, but can they show me? Can they demonstrate physically how to do that process or that dosage or whatever it is that you're teaching them? The second point there, it's not a test of memory. If you're giving them materials, if you're giving them tools that they can use to help them at home, let them help it when they're teaching it back to you. You want they have that for a reason, let them use it. If there's a misunderstanding, you want to clarify that and then check again that clarification was understood. And then the chunk and check is just basically when we're teaching something, when we're giving our post-op instructions, you don't want to do everything at a time and then have the patient recite everything back to you. We want to try and break it off into smaller pieces, smaller chunks. Chunk that information, provide it, have the patient teach it back. Move on to the next segment. and just kind of go through and repeat it throughout this day until we get to all the information. Very helpful when we're talking about more complex instructions and things like that. There we go, one slide, sweet. Teach back, again, just 3 or 4 more things of the most important things. You don't want to try and teach everybody everything. That's important when you say, this is kind of tips. How we make it work at home. We've gone over a lot. What can you tell me what you heard me say? Oh, you're going to go home. I'm sure your wife is going to have tons of questions. What are you going to tell her about this? Right? So that's more, you want to, I always joke when I sit down with a new patient safety officer that I'm going to throw a lot of information and I fully expect them to forget half of it. And the literature supports that. When we get a lot of information, complex information, we don't recall it all. And the bits of it we do recall, a lot of times that's incorrect. So the more reinforcement, the more repathing we can do with that information, the better it's going to be, the better it's going to be retained. Some more suggestions. How do you understand the plan? Tell me how you take your medications. Again, show me how you make data. Show me how you're going to take your medications. And we can do this. We can put the onus on ourselves. So you can see, I want to make sure I explained it correctly. It's not, I want to make sure you understood with your little brain, what I was explaining to you. No, it's, hey, we're doing a lot of work on health literacy and making sure we're having good patient outcomes. And I just want to make sure that I did a good job explaining that to you. To make sure I did, can you tell me what I said to explain to you? And frame it that way. You're going to get much better reception from your patients. What to teach, you want to focus on actions. You can see that those definitions that were updated for 2030 focused on that actions. We don't want to do duplicate paperwork. We don't want ancillary information like, oh, you might have had, here's information on, I don't even know, but something tangential we don't want to provide. We want to give, because the more papers you give somebody, the bigger the chance they're not going to read any of them. If you give somebody one paper, they're much more likely to read it than if you give them 9 different ones, right? Collaborate with the next sites of care if you want to be consistent. If you're making sure that you're referring to these conditions to the treatments in the same way, that can be very helpful for patients. And then the Ask Me 3 questions. Many of you are probably familiar with the Ask Me 3 tool. Here's a quick snapshot. It's from IHI, basically saying that patients need to ask, what's my main problem? What do I need to do? And why is this important to me? Okay. How to teach, you want to ask, I mentioned having different materials, plain language. I'm getting a little repetitive here. If anyone else wants to explain to me or show me how you'll improve health literacy in your facility, that would be helpful. But these are the kinds of things that you want to take an emphasis on when you're looking at your staff. So how do we do it with an organizational? We're saying we want you to do teach back. You need to train your staff how to do that. You want them to share stories of like, hey, I asked someone to explain it to me and they used their inhaler and squirted it, around their neck. Anyone seen that house clip? It's popped into my head. You're going to have funny stories to share, and that's going to deeply root the teach back method in your normal practice, right? Make it part of obtaining your informed consent. Right? We're having those conversations. We're explaining the risks. We're explaining the benefits. We're asking for that decision. We're asking for that consent. Have the patient explain to you why they're giving that consent, what they consider, why they feel it's okay to assume the risks of whatever procedure or whatever we're doing, whatever treatment we're providing. If we're giving written communication, we want it organized. If we're using bionic reading, we don't want bionic reading everywhere. Maybe we don't want bionic reading. Let's look at our patient mix and what kind of information we're trying to relay. The content should be as plain, as relevant as possible. Like I said, don't avoid. I know we want to throw in it'll be great if they know, or if they have questions, then we can give this information. No, if they have questions, give them a place to seek out questions and make them feel comfortable and trusting and comfortable enough that they can reach out and ask those questions after the fact. That'll, again, will serve you better than just trying to include as much information up front to avoid those questions. Right? You want the relevant information, start with the background, but you want it just the need to know. Again, you don't want tons of background information. And then you go into the logical flow. This is the conditions that were present. This is what happened. This is where your condition is now. This is what the treatment's going to be to get you to this next condition, which is at time we will do this treatment. Those kinds of, keep it chronological, keep it very flowing. Keep it putting it into sections. Okay, background. This is how we're going to handle medications. This is going to how we handle, radiation treatments. This is what we do before and after our appointments and those kinds of things. All right, make it as easy to digest as possible, and it's going to make all of our lives easier. And on the flip side, I'm just like completely going a page down here. I'm not sure why. Short, familiar words. Your sentences shouldn't be more than 15 to 20 words. If you can keep them shorter than that, that's great. Acronyms. I mentioned jargon, slang, those kinds of things. Acronyms. Man, we love our acronyms in healthcare. If you use an acronym, please make sure that you explain it. If you can avoid them, that's great. I know sometimes it does make things a lot easier, but make sure that you're explaining. Don't assume that the patient is familiar with an acronym, even if it's related to their disease state. They might not know what COPD has, even though they've been diagnosed for 10 years. So just keep that in mind. I mentioned the numbers. That's always a tricky thing. And again, your tone, your approach, how you're greeting patients, your treatment environment should be catered to whatever cultural factors are at play in your patient population. Again, I'm not going to go into that too much today, but it is a topic, if you're interested in hearing more about, that I think is important. White space is always good. If you have a slide like this with just a ton of information, people tend to remember less than if you have a slide like this, where it's just a couple things and lots of white space, right? Keep that in mind. Bulleted lists. This is good. This is with your sections. You can divide it out. And it's very easy when you're doing chronological steps. Keep those just bulleted out. Make it easy for people. That way they're not going to lose their way as they're going through it. If you list out steps in a paragraph, I'm not going to be able to, I'm going to read a step. I'm going to try and do it or look what I need to do. And I'm going to go back to the next step. Make it easy. Okay. This is basic stuff. There's tons of tools out there within ARCS materials and elsewhere that you can use to assess your written materials. And it's something I really do suggest that you do. And I suggest you involve not just clinical staff. And keep in mind, not just clinical staff are the ones always giving out information. So when you do your training, when you do your assessments, include all of your staff, because everybody's interacting with patients. Everybody's relaying some type of information. So it's important that everyone's on the same page with that we have that shared understanding as an organization of what promoting health literacy really looks like. Okay. So on that note, we've had our dinner. We made sure all of our patients are fed. I'm gonna send you all home with a plate of leftovers. Here's my plate of leftovers here, right? We want to, what do we do? What's our takeaways? We want to make sure that the people we're serving can get information that they need. We want to be able to provide that. We need it without jargon and different languages. We want to focus on just the top 3 things. We want to make it action oriented. I'm encouraging you all to use some type of teach back methodology, whether it's a formal tool, teach back method, show me method, whatever, some type of teach back methodology is going to serve you well. And then really, we want this teaching to take place. If we have a patient for 6 days, teaching should start on day 1. We shouldn't just try and cram everything into that discharge planning. The more we can segment it, the more we can chunk and check, the better. And we don't necessarily have to do that all in one session. We can do that over a period of days. And that gives you an opportunity. Oh, hey, we talked about your process for managing your CPAP at home, machine at home last night. Can you explain to me what we went over? Did you have any questions about that? Can you walk me through the process of how you're going to do it at home and see if there's something I can help clarify? Something along those lines. We want to take advantage so it's not as burdensome to try and do this all at one time when it's time for the patient to go. Okay? With that, I'll point you guys to references, and I'm going to turn it back over to Kelly so we can open it up for questions, and I'll wish everybody a happy Thanksgiving next week. Enjoy the food and football.
Thanks, Chris. That concludes the slide presentation portion of our program. Now we would like to begin our question and answer period. I'm just looking through and I saw something come through that talking about motivational interviewing as a strategy to address health literacy. Can you give more information on that, Chris?
Sure. So I think I'm gonna jump back to the slide. I think it was I mentioned it on slide 30 with the ARC toolkit. And the ARC toolkit does have some resources on motivational interviewing. It's it's more of a clinical skill that's focused. It's real big. My background's in behavioral health, as I think was mentioned in the intro. So this is something that's been around in behavioral health for a while, is trying to meet patients where they're at, what their stage of change is, how motivated they are they to make changes, and how can we tailor our interactions to further motivate them and get them to go through those different steps. So really, when we're applying it to health literacy, it's not a perfect fit, but you want to make sure that you want to make your patients feel comfortable. You want to show the benefit of kind of progressing through the steps of a process to reach a goal. So it's goal focused, but not just goal focused. It's focusing on where the patient is, meeting them there, and providing the information to help them get to not necessarily the end goal, but just the next step. And then we're motivated to go to the step beyond that and kind of again chunking it out. Again, that's a very high level explanation, brief explanation of motivational interviewing. It's really applicable in almost all areas of clinical care. But when discussing health literacy, that's really what we're talking about, is to just to kind of help with some of those complex conditions and break it down and make sure that our patients don't get overwhelmed and shut down. Okay.
Thank you, Chris.
Yeah.
Said about using the Q&A panel, but it's the chat panel. So use the chat panel to enter your questions, and we will get to them as we can. Is there a specific resource recommended for plain language alternatives for specifically like the medical terminology?
Oh, nothing specific. I do suggest that you have some type of, thesaurus, dictionary, whatever you want to call it, of jargon, just for staff to kind of help. It's helpful to go over if you're doing training with them on their patient education and patient communication and things like that. It really comes down to your clinical setting and what your specialty area is. There's some comprehensive ones out there through like HSS, and CDC has one that kind of covers, the A to Z. I don't know if you guys need to have something that comprehensive. So I wouldn't recommend something that specific. You can find something that's a little more tailored to your specific clinical area. There's also options available out there for patients, that might be worth a look as well. I think there's like a patient medical thesaurus or something along those lines. But no, there's no specific resource that stands out as like a gold standard. You can even Google it and you'll find a ton of different, medical term to plain language dictionaries. So even if you just pick a handful of terms, that can be very beneficial.
Thank you, Chris. So another question is, can you speak more to the potential cultural impact on patient health literacy?
Ugh. See, that's why I said this is a good topic for a whole nother webinar, whole full webinar. But really, our cultural aspects it's not just language. I know when that comes up, my head usually goes to language first, and of course, non-English speakers, non-English proficient patients do present a challenge that needs to be addressed. But there's also cultural issues there, that not just cultures outside of the U.S., but subcultures within the U.S. If there's a minority group, Black patients have shown to have a lot less trust with their healthcare providers than Caucasian patients, and that's based on cultural experiences, I'm sure, and reactions they've gotten from authority figures and institutions in the past. And I'm not going to get too much into it, but you can see how those, even if they're just perceptions of the patient, can have an impact on their understanding on that communication. So when we go back to that number one barrier, that perception, oh, if I'm speaking to somebody and culturally, when somebody of authority speaks to them, they're from a Southeastern Pacific Asian culture, and when someone of authority speaks to them, it's rude to question the authority, so they just nod, and I take that as an understanding. That can be problematic, because now I've made the assumption based on that cultural blindness that they have an understanding. So it's things like that can really come into play. But there's so many factors and so many ways in which cultural and background can play into our interactions, that there's no way it couldn't have an effect on health literacy.
Thank you. The webinar will be ending soon, but we have time for a few more questions. So if you have anything you would like to ask, please type them in the chat box. I know, Chris, you had kind of listed out some strategies as we are kind of winding down and wrapping up. Is there any one thing that, our participants today, if there's one thing they could work on, what would you maybe suggest or recommend to get started?
Ooh, um, do a teach back the next time you do informed consent, or the next time you're involved in informed consent. I think that's an area where we don't always think of it as, like discharge instructions or pre-op instructions. We're providing information and expecting them to follow instructions. I'm not sure if we always approach informed consent with that same mindset. So I think that would be good to kind of extend our thinking to health literacy to that process. But other than that, just an awareness that, people are they're coming in not at their best. They're sick, they're stressed, they're confused, they're dealing with a whole host of activities. We really want to do whatever we can to make it as easy for them as possible. And that's going to have better outcomes for them. It's going to be, better financially for our organization. It's really what we should be focusing on from the moment somebody comes through the door, is we want to make sure we're giving them that good, I don't want to say customer service experience, but health literacy and meeting people where they're at is an important aspect of that customer service. So just being aware of it and addressing it throughout all steps of your client communication and interactions. That wasn't really one thing, Kelly, sorry. That was several. I'm aware of it.
You get extra points for that.
I think I left it to 3 though. I didn't go more than 3 because then everyone's gonna be.
Well, as we're winding down, I will share one story that I've shared for years. And when we talk about being on the same page, wavelength, whatever it is, with our patients, I was interviewing patients related to falls, and I was going into a patient who was at high fall risk, meaning that they had a previous fall at some point prior to hospitalization, I think. And in talking with the patient, and there was a family member there, it was, hey, what was your history? Like, what happened that you had these falls in the past? And she's like, I didn't fall before. What are you talking about? I'm like, oh no, I'm in the wrong patient room, right? And then as we kind of dug in a little deeper, found out, oh yeah, I go to my knees all the time when I go to get up. Wait, what? I thought a fall was a fall, right? And I thought that everybody kind of knew what that was. But in this person's mind, this patient, they were not thinking of what they did as a fall when clearly they were getting somewhat syncopal as they went to stand up. So I like to share that story just to be thinking that I think that is one thing that we are all on the same page, right, about when it comes to falls. But we have different perspectives, different histories, and different backgrounds that brings a different interpretation to the table. So, Chris, do you have anything that you would like to share as a final thought before we wrap?
No, Kelly, I don't think I can top that. That was a great anecdote. Thank you. That's perfect. No, it's a perfect depiction of even though we think something's common knowledge, we have different understandings. You're right.
And it takes a lot of patience and it takes a village. So with that, we thank you all. We will be wrapping up here. I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or certificate of continuing education, please feel free to direct any inquiries to Shelley Meixel at shmixell@pa.gov. This concludes our webinar. Thank you.